If you're only looking for STEMIs, you're going to miss a large group of people who need the cath lab just as much as an ST elevation. And not just be so focused on the EKG where when I see no ST elevation, I'm like dismissing everything you say.
Exactly.
I can't do that.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
So we've got some exciting, I say that every time, exciting topics, but this is
always exciting, Matt.
Yeah, they're always good topics.
We're talking about the human body. There is not a more interesting machine on the planet than our human body, I believe. True.
Super complicated, but we're...
Wonderful.
Yeah, it's amazing how the human body works. If you like our page, if you like our content, subscribe to our page, hit the like button, make a comment on this video. That helps us out. So, as a firefighter paramedic, one of our big things is STEMI recognition, right? That's a big deal, is you got to be able to recognize STEMIs and not miss STEMIs.
Would you say that, is there a bigger red flag? When you're going through school, recognizing a STEMI? Maybe cardiac arrest?
Well, yeah, cardiac arrest would obviously be huge.
But the STEMI, though, the heart attack, that's a big deal.
So when I think about, activations, right, through my career, even when I started, we didn't do, stroke activations, right? But when I started, we did do STEMI activations, right? And, obviously that science has progressed, and now it's progressed even. There's a new term, catchphrase, and just to be clear, we're still talking about myocardial infarctions, heart attack, whatever word you want to put on it. We're still talking about blockage in the coronary arteries, reducing blood flow to the heart, right?
Right.
But we're not necessarily, STEMIs, that term is kind of going out, right?
Well, I think it should. The term itself is good because an ST elevation pattern on an EKG is badness. Right. And we need to recognize that. That's good.
Yes. It is one indicator of a heart attack, but it's not the only one. And we've been taught for so long that, and we say this, I've said it numerous times, a 12 lead talking to a patient, this isn't definitive. We got to get you to the hospital. We got to draw labs, blah, blah. But, I know obviously there's things like NSTEMIs. I've had patients, and I've always thought and been taught, treat your patient, not your monitor. Right. I've got a patient that's pale, diaphoretic, they look terrible, they're complaining of chest pain, and I do a 12 lead and there's nothing there. Yeah. I'm still calling that a STEMI, or I'm still, in my mind, calling that a heart attack, maybe transmitting. But now, with this new phrase, there's other things we need to be looking for.
Well, I'm telling you, we're on the tip of the spear here, Matt, because there's a lot of hospitals. I'm not going to name any names here in the DFW area. Right. Fourth largest metroplex in the country. Right. We should be up to date. Right. We're missing about a quarter of occlusive pathophysiology by only looking for STEMIs. Right. What that means is, and we talked about this, this, but if you're watching this or listening to this and you didn't know this, if you're only looking for STEMIs, you're going to miss a large group of people who need the cath lab just as much as an ST elevation.
Right.
I'm going to back up just a moment, Matt, because I think this is a good reminder. When we're talking about sepsis, it's not all about QSELFA and SIRS criteria and trying to identify people. That's a big part of it, right? Yeah. But the problem with sepsis is that you have somebody with an infection that's affecting their physiology and they can't maintain perfusion. Right. That's what's going on. Right. Stroke. You've got an occlusive lesion in the circulation to the brain, and the brain cells are going to die if we don't get that circulation back. Right. Same thing's happening in the heart. You get blockage of the heart, blood, and the heart cells die if you don't reperfuse them. Yep. That's what's going on. That's the pathophysiology. Same thing for trauma. Yeah, if you damage the hoses. Yeah.
It's all related to the distribution of blood.
It is. Yeah. So that's what's killing people. So we're focused today, like you said, eloquently and perfectly. You said we're focusing on the STEMIs today. This is those occlusive lesions. So OMI is a better term, an umbrella term for anything that needs reperfusion. Right. Again, if we are hyper-focused like many hospitals are, they only activate the cath lab if there's ST elevation. Right. That hospital, STEMI. Right. You're going to miss a large portion of people. We could be missing as much as a quarter of the people with that pathophysiology of occlusion. That's why we call these occlusive myocardial infarctions, OMI, which is a better term in my opinion as a physician, and I know you and I agree. This is what we need to be looking for, and I think, in my opinion, that the term STEMI is hopefully an old term.
Well, I think that it's still a term that's relevant because we're still going to be looking for ST segment elevation.
Absolutely.
What we have to be aware of is that that's not the only thing that could indicate a possible occlusion
I would wager to guess that most people in the back of an ambulance are looking at the EKG. They say, oh, no STEMI.
1,000,000%.
We need to focus on those situations where it may not be a STEMI, but it's just as dangerous as a STEMI. Those other 5 patterns we're going to talk about today that you need to know. I think this information needs to get out there to everybody.
Yeah.
And I hope that this gets forwarded, distributed. I mean, if you hear this and you've never heard it before, I think you have an obligation to spread the news on this. Yeah. And we need to get this out because there are a lot of people missing our family members potentially, or they're going to miss the EKG pattern. And we're talking about minutes that count for those little cardiac myocytes that are dying.
And we're going to do a true 1 hour long CE on this.
We are.
But this information is very new to us, this term.
Well, yeah, the term is
new to us. And we felt so impassionate about it. It was so important that we wanted to get it out in some form. So that's why we're doing this podcast on it.
I'm going to defend you and me though.
Okay.
Because we covered 4 of the 5 pretty thoroughly.
If
you watched our STEMI lectures, we called them STEMI mimics or STEMI equivalents.
Right.
But again, the problem is our hospital system isn't activated. We don't activate cath labs on some of these patterns, which we should be.
Yeah.
And we're missing them. And I think some of us in the pre-hospital environment aren't even aware of this. The ones I've talked to.
Yeah.
We need to get the word out on these things.
It seems like a lot of times and a lot of things like this that have come up, for example, like end-tidal. The pre-hospital providers are usually really quick to change, or not change, but update their practice as opposed to the hospital system. I'm not sure why that is, but like I've gone in, like, you know, in my department, we're very well educated on the correlation of end-tidal with sepsis. That, you know, end-tidal readings of 25 or less typically correlate with fairly high lactate readings in the hospital. And I can tell you from my experience that is held true. When I have had a patient that I'm calling sepsis on because they're meeting the Sears criteria or whatever, I will always throw them on end-tidal just out of curiosity to see what their end-tidal is. And almost 100% of the time, if their end-tidal is low, their lactate has been super high.
And what does that mean when the lactate's high? They're not perfusing organs. Correct. And those organs, to survive, are going through alternate means of metabolism.
Yes.
And they're using things that are inefficient, and that's how organ systems shut down.
Yep.
So when you get a high lactate, that's kind of like that last-ditch effort. We're shutting down if we don't get this fixed.
We're shunting. We're doing, it's like trauma. It's the same.
Right.
Yeah, exactly.
Same thing here, back with the STEMIs.
Yes.
Again, it's all about the fact if you block coronary arteries, you're going to see a patient potentially complaining of chest pressure, an elephant sitting on the chest, radiating pain down the arms up to the jaw, diaphoresis, and nausea. These are classic signs, those high, what we call in medicine, likelihood ratios of association with a heart lesion. Again, if you see a patient that's complaining of chest pressure and they're vomiting, that's a bad sign. Radiating pain, right? Like Adam says, you know, danger.
Right.
So that's the key. That's the key here. So let's should we start?
Yeah, let's go through them. Yeah. There's how many?
There's 5.
Okay.
5.
Yeah. And we hit 4 of the 5, but there's one that was kind of new to us too that we kind of had to do some research on.
Oh yeah.
So don't feel bad if you're a paramedic or even a physician out there like, I've never heard of that.
Yeah, there's certain EKG patterns that I kind of said, that's for the cardiologist to worry about. I'm not going to trouble myself with that because you know in the ER and I think it's true with paramedics in the pre-hospital environment. It's like, just tell me what I need to know. Yes. I don't want to waste time with a bunch of esoteric little geek outs. I don't need to prove to anybody I'm smart. I just want to know what I need to know to save my patients.
Yes.
And so honestly, I thought some of these patterns we're going to talk about today, I didn't need to know. So I kind of blew them off. I learned them in medical school and in residency.
Yeah.
But since then, it kind of mothballed them.
Right.
but I got to take them out of mothballs and I got to memorize them. So we're going to talk about those today.
Yeah, cool. All right, so 5 different.
Yeah.
What would we call these? Not STEMI mimics, because it's I would say like EKG patterns indicative of an OMI or something like that.
Good. Yeah, I think that's a good description for them.
Make an acronym for that. I don't know.
Yeah, I know. Well, again, an OMI is a term that will cover all occlusive lesions, that pathophysiology of blockages in the coronary artery system that are going to kill your heart.
Right.
Some of those patterns won't show up on a STEMI EKG. Right. So to get all of them, we need to learn these 5 patterns of occlusive pathophysiology. I don't know, that's how I'd say it.
Yeah, that's
what you said is probably better, but you've always got good terms.
Occlusive OP.
OP.
You could just call it OP.
As long as you understand that these are not STEMIs, and if you're not looking for them, you're going to hurt your patients.
And also, like we talked about in prepping for this, it's also important to remember that the pathophysiology that we're talking about is not changed.
No.
We're still, again, I said it at the beginning, and I think it's important, especially for our firefighters and our EMTs and paramedics, to understand is that we're not talking about anything different that's happening to the heart. All that is the same. What we're talking about is new things to look for on your EKG. It's not just about looking for a quote-unquote STEMI. Yeah. There are other things, 5 other things that you need to look for. If you don't see ST segment elevation, you need to look for these 5 other things because they could be just as indicative of a heart attack as a STEMI.
Do you want me to tell you how smart you are? And if you're listening or watching, how smart you are? I don't look at the camera very often, but we're talking to you. But we have all felt this. You and me, Matt and I, we've all felt this. Have you been in a situation where you're like looking at the patient, they're gray, and it's like, oh, STEMI for sure. I bet money on it. EKG comes out. Oh, there's no STEMI here. Dang it. You're right? And you don't activate it, and you go to the ER, and you drop them off, and maybe they go into cardiac arrest. Who knows? Or maybe that next subsequent EKG shows STEMI. You're like, that didn't...
I knew it.
Right. Yeah. You felt that, right? Or maybe they're an NSTEMI, and you're like, oh, well...
That's why I say I always treat... I had that exact case. Guy that had had multiple MIs in the past.
Yeah.
Called us to his house. Yeah. Guy was diaphoretic. I mean, just crushing chest pain. The whole classic symptoms. And I'm thinking, oh, we're going to run this, have this. Yeah. Nothing. I still activated.
Yeah. Oh,
and
good.
the ER physician walked into the room.
Oh, no.
Said, where's the 12 lead? And it wasn't the 12 lead. It was the story, right? It was the presentation. Yeah. That doctor took that 12 lead and said, this isn't a STEMI, literally threw the 12 lead on the bed and walked out of the room.
You know what? He was right. It wasn't a STEMI.
That's true. It was not. There was,
and that's the problem because hospitals are so focused on STEMIs, and that is. And listen, I'm going to defend my cardiologists here and my ER doctor colleagues.
Yeah.
Is that based on the data, we cannot activate the cath lab. And if we did that on everybody that showed a potential ACS or acute coronary syndrome or a potential heart attack, we are actually causing the system harm by inappropriately activating the cath lab on anything but a STEMI.
Right.
But we've learned more now.
Yeah.
And there are 5 patterns that we need to know. And I hope hospital systems hear this too. Send this podcast to your hospital and nurse leadership or whoever you have in maybe your EMS liaison, because we need to rethink, I believe, some of how we activate our cath labs in the hospital to support our pre-hospital providers who are recognizing these patterns, because it's frustrating for us. When we recognize a pattern, we go to the hospital and the doctor does that. And I'm sorry that happened. But I've been there too. It's like, but I don't think I've ever said that or like.
Well, yeah, I wouldn't see you saying that.
No.
Yeah. I got my justice later when they draw troponin and his troponin was through the roof and he was having an MI.
Here's how I would have handled it. And again, I'm no holier than anybody else, right? This is the way I handle things. So if you're an ER doctor listening, I think you got to hear this. Because some ER doctors don't understand the pre-hospital environment like I do, right? And so when you're bringing in an EKG to me and you feel like this is something really wrong, I need to listen and not just be so focused on the EKG where when I see no ST elevation, I'm like dismissing everything you say.
Exactly.
I can't do that. I have to listen. And we cover a lot of the presentations of these OMIs in our other lectures.
Yeah.
But today we're talking about EKG patterns.
Right.
So let's talk about the 5 EKG patterns that won't show up as STEMIs.
Right. And the one last thing I'll say before we get to the 5 is if you're a pre-hospital
You can say 2 things if you want.
All right. We'll keep it to 1. But if you're a paramedic, right, because EMTs typically don't do 12 leads. Anyway, if you're a paramedic and you're running a 12 lead and you suspect your patient's having an MI.
Yeah.
And you're seeing one of these 5. Right? And you want to activate because you just watched this podcast and you're like, I'm cutting edge. This is an OMI, right? Send I would recommend that you transmit the EKG to the hospital, call, ask to talk to a physician and say, hey, this is why I think we should activate and this is why.
Right.
It's one of this patient's meeting one of these criteria.
Yeah, we do our job. That's all we can do.
Exactly.
And hey, I think we should activate the cath lab. It's not ST elevation, but this is a EKG pattern.
There's data to back it up.
You can say what you want,
right.
and if it falls on deaf ears, that's on them.
But
we got to be advocates for our patient.
100%.
Right? Don't acquiesce. Push hard.
Right. Yeah.
And anyway, so let's talk about it.
Let's talk about the 5. Okay.
So I think the first one, again, it's subtle. But we look carefully at for an inferior MI at leads.
I'm glad you started there.
2, 3, and AVF, right? Yeah. We all know that. That's like 2, 3, and AVF inferior MI. Everybody's got that memorized.
Get the blood pressure.
Be
Don't
careful
give them
with
nitro.
the nitrates.
Yeah.
Be careful with Ask them if they have erectile dysfunction. All this stuff, right?
Yeah.
Avoid morphine. Just because, again, with an inferior MI, you're hitting the right side of the heart, and you can really hit the preload. Yeah. So we know that. We're not going to go over a lot of that. Watch our lectures if you want to review what an inferior MI does. But the key here is that based on data, any elevation in 2, 3, and AVF should be highly suggestive of occlusive pathophysiology or a heart attack. Right. So if you stuck to the guidelines for an inferior STEMI, ST elevation, you got to meet criteria of 1 millimeter in those leads, right? Because an EKG that shows maybe 0.5 millimeter, just subtle elevation, kind of hard to even pick up, but you're concerned. It caught your eye because you're a great paramedic, EMT, and you know that look weird, right? Yeah. Well, it doesn't meet criteria for STEMI because it's not a millimeter, so it's not a STEMI.
Just run them code 1 to the hospital.
It's not a STEMI. Well, it's true, dang it. It's not a STEMI.
Yeah.
By that criteria.
Correct.
But what we're saying,
doesn't mean it's not an MI.
Right. The data shows that even subtle elevation, and the reason for that is, as we've talked about.
Yes, this is your explanation is awesome.
Yeah, but we both know, we've talked about this in our lectures, what causes the deflection for ST elevation, the movement of the line on an EKG above baseline that we're looking at. It's all about the amount of heart muscle, the amount of electrical activity, and how close it is to the lead. Those are variables, right? Well, the right side of the heart doesn't have a lot of muscle.
Right.
So if it's deflecting a lead, that's pretty significant. And I think that's why we need to be more careful with the inferior MIs because we're dealing with minimal heart muscle.
Right.
The left side of the heart, big, thick, muscular heart, easier to move those EKG blips on the paper.
It's if you think about it, and you're gonna laugh when I say this.
I'm not.
But it's kind of like think about me as the right side and you as the left side. No, but I'm gonna be able to. I'm gonna probably generate less energy because I am a smaller framed guy than you. You're a big, strong football player, dude. You're gonna be able to.
You're so good at calling me fat. You know, you're like.
I said you're a big, strong.
I know. I'm big boned, right? No, I'm kidding. You're right. It's a good analogy.
But I mean, if you think about it in that, I'm going to generate less energy than you are, right? But that doesn't mean that our output isn't the same. No. We're both trying equally as hard, but I simply can't do it as much because I don't have as much muscle mass as you do.
Now, the other thing is we could have the same muscle mass, and I could be more fluffy and have more fat outside of my muscle, like fat between the lead and the heart, and I will have a smaller deflection than you if you're more fit because the lead's closer to the heart. So a lot of factors can affect the deflection. Lead placement, all of these things. So back to so this is the first pattern we're talking about, an inferior MI with any elevation at all.
Does it mean reciprocal changes?
Well, reciprocal changes also should increase our suspicion, but I'm just talking about the leads.
Any sort of
elevation in 2, 3, and AVF is highly suggestive of blockage in the coronary arteries on the right side of the heart.
So use that maybe in conjunction with your patient presentation.
Yeah.
And be highly suspicious. Transmit your EKG. Yep. Talk to the physician.
So in this case, you've got an inferior elevation. I would follow your protocols, but I would recommend you activate the cath lab.
Well, we don't activate
the EKG say,
right?
Well, I mean,
we could activate a STEMI.
Yeah, but I'm saying when you call a STEMI, they will activate the cath lab if they're smart and if they follow their rules.
Yes.
And I would stand by that EKG. If it's inferior and you see any elevation at all, I would activate the heck out of it. Talk to your medical director. Talk to your FTO. Talk to your leadership within your EMS training division and talk about these things. Be on the same page.
Yeah.
But I'm just telling you, I'd activate it. If I was on a ride out with you, Matt, and you and I saw this EKG, you and I'd be lock, stock, and barrel. Isn't that the right term?
Sure. Sounds good.
We'd be together, unified.
Yeah, we'd be unified.
Holding hands.
Lock, stock, and barrel.
All right, that's the first one. So.
All right, so that's the first one. So any elevation, 2-3 AVF.
Yeah.
Be highly suspicious, activate, transmit, all that stuff.
Okay, let's go right to the weird one.
Yes, this one's odd.
Well, it's not weird. I mean, we all learn this. It's just that it's just not one of those things we see a lot or look for a lot. So let's learn something.
Yes.
And we'll spend more time on this maybe than the other ones.
And I think this is probably going to be a 2-part podcast.
Yeah.
Because we don't want to rush this. We want to make sure that we get this information all in. So
Fair enough.
Go ahead.
So this is called a bifascicular block.
Okay.
So you got fascicles. Basically, these are the conductive conduits of electricity through the heart, right? And when you break one of these or damage one of them, it creates EKG patterns. Right. So bifascicular block means you're blocking the right and the left. And when you block them both, highly suggestive, acutely, what that means is like, the old EKGs never look like this. You obviously can't compare old EKGs here. Yeah. But if you see somebody that looks gray, like it's a STEMI, and you see the EKG pop up and it's not a STEMI, you're like, oh, I guess it's not. Oh, wait, hold on. I remember Matt and Erik talking about this. Oh my gosh, here it is. This looks like it could be a bifascicular block. This is highly suggestive of a left anterior descending lesion. Remember the widowmaker? This pattern,
the big
highly suggestive of a widowmaker.
Yeah.
Listen to this, please. If you're watching or listening, here it is. If you see somebody looking sick and you see a pattern on that EKG of a bifascicular block, highly suggestive of occlusive lesions in that coronary system of that left anterior descending artery. So here's the bifascicular block. So let's talk about, first of all, you need to have left axis deviation. Right. There's 3 things we're going to talk about here.
Yes.
So.
And everybody loves axis deviation.
Right. We'll talk about that, and then and so this is part of the fascicular block. So this is part of the left anterior fascicular block. This is half of what we're looking for here. This is honestly, I had to go look this up because I don't look for this anymore, but I do now.
Yeah.
We need to have this memorized. Yep. So here, just a quick lecture on this. And again, we're going to cover this in some of our OMI lectures later. But a left anterior fascicular block is going to be characterized by these 3 things. And again, generalities here. There's some subtleties we're not going to cover, but this is the basics.
Right.
So good first step.
Right.
So left anterior fascicular block, you're going to need left axis deviation.
Right. So
left axis is a quick review. I look at leads 1 in AVF. There are other ways to look at it too, but just looking at 1 in AVF.
Let's make it simple. Yeah.
So if they're both up, we're good.
Yep.
Normal.
2 thumbs up.
Axis. Yep. Normal. Now, if you're up going in 1, which is good, but you're down in AVF, that's bad.
Yeah.
So we're pointing down, right? So if I push down on the turn signal, what way am I going to turn? Left. It's a left blockage.
Deviation.
Sorry. Left axis deviation.
Yeah.
Thank you, Matt. Thank you. Now, again, normal.
Yeah.
Left axis deviation. Now, if this is normal, right, but the 1 is down, now I'm pushing the turn signal to the right on AVF. So now I'm going to turn right. So that's right axis deviation. Okay. So,
correct.
So if you are up going in 1, down going in AVF, that's left axis deviation, quick and dirty.
Yep, I like it.
That's one of the 3 for left anterior fascicular block. The other things that we talked about, which again, we have to review these. If you look at leads 2, 3, and AVF, and you see QR complexes, that means you got a Q wave
which is the first negative deflection before.
Like a little Q wave.
Not everybody has Q waves. That's important to remember.
True.
Typically, you won't see those.
And again, this is 2-3 AVF, highly associated with this left anterior vesicular block. You got the left axis deviation plus a QR complex in 2-3 AVF. So 2-3 AVF QR. And then if you look at 1 in AVL, you have QS complexes. That means you've got that Q.
Positive and negative.
Yes, correct. Sorry, does that make sense? We good?
Yep.
Okay.
Yep. Makes sense to me.
All right. So this is key for the left anterior fascicular block. Now the other half of this that gives us that STEMI or that occlusive MI pathophysiology is we have that left anterior fascicular block that we just talked about, left axis deviation plus QR complexes in 2-3 AVF, QS complexes 1 AVL, left anterior fascicular block, plus a right bundle. A right bundle.
Acute right bundle.
Acute right bundle. And whether or not it's acute, those are things that...
And that's going to be hard. You can ask, have you ever had a right bundle branch block? And they look at you like you're speaking...
But if I saw this with a sick-looking gray patient, and I'm in the ambulance, I'm telling you what I would do, follow your protocols, but I would transmit this, and I would talk to that ER doctor, whoever receives that call, and I would say, I would activate this. I think it's a STEMI equivalent.
It's our job to look for patterns. It's not our job to diagnose MIs. Nope. It's not my job. My job is to look for patterns of illness processes. And if I see any of those patterns, to tell you, this is what I'm seeing, but you went to school for a whole lot longer than I did. I tell people this all the time. I went to paramedic school. My paramedic school is 6 months. You went to school for a decade. I think you probably studied a little bit more in depth than I did. So I'm going to refer to your expertise. And then you're going to do what?
Well, I'm going to do the right thing, I hope.
Right. But I mean, a lot of times you're going to consult with a cardiologist who that's all they do. So I tell paramedics this all the time. Don't get so confident in your EKG skills that you're not willing to go, something looks off here, but I know everything about EKGs and this isn't anything.
No. I call that hubris.
Yes. Exactly.
That is not a good place to be. We want to stay humble.
Absolutely.
And always want to learn things. You say, hey, Axene, you've had 10 years of education.
Yeah.
Well, I have, right? But I have to realize that I can learn new things. I'm be honest with you, and maybe I'm an idiot for saying this, but I had to go look up a left anterior fascicular block. I forgot, and now and again, diaries from an ER doctor. Confessions from an ER doctor.
That could be another one.
No, this is really actually scary to think about, is how many STEMI patterns have I overlooked?
Yeah. Oh, I mean, there's no doubt. But again, that's the beauty of always learning, right? It's the beauty of if you graduate medical school or you graduate paramedic school and you think, okay, I'm done now, I'm a paramedic. No, bro. Yeah. Like you just passed the test. Now you got to learn how to be a paramedic.
Well, let's put the cap on this before we finish part one here, Matt. Yeah. So for this second pattern, we're talking about that won't show up as a STEMI, but it is indicative.
It's a STEMI equivalent.
Yeah, STEMI equivalent. That's a good way to call it. But this is one of those patterns of occlusion of a coronary artery that won't show up as a STEMI, this bifascicular block. So we talked about the left anterior fascicular block. Again, to review, we got left axis deviation, up in 1, down in AVF. We got the QR complexes in 2-3 AVF, the QS complexes in 1 in AVL. I think I did that right.
That sounds
right. Did I do that right? Or did I slip it up?
It's QR and 2-3 AVF, and then it's QS and 1 AVL.
Boy, I may have flipped that. We may want to review that. I think I did it right. Didn't I do that right?
Oh, you got your thing there. Let's double check it.
I think I did that right. Yeah, I hope I did it right.
This is super complicated. This is not. I mean, there's a lot of factors to this left anterior or the anterior fascicular. I can't even talk. Block. So it's important that we get it right.
I think so. So we have.
I'm looking at the EKG.
I'm looking at it, and it is. I'm looking at this is 1 and AVL.
Should have RS.
Yeah, we have RS, and 1 in AVL. And then we have
2, 3 AV and F.
QR. Good. Yeah. We did it correct.
We said it correct.
Okay, good. I just want to make sure.
Yeah, no, absolutely.
And as we close this out, a right bundle, you're looking for those rabbit ears.
Yeah. Rabbit ears and V1.
And
Work
V1.
Backwards, look for that turn signal method. Yep.
Good.
If it goes up, that is a right bundle branch block. If it's going down, that's a left bundle.
If you're not looking for these patterns, you're missing people that are very sick, and that's not 100%. Good. So hopefully this will change your practice. Spread the word. Forward this to people.
And stay tuned for part 2.
Yep. And man, it was a good talk. Good contact.
See you in part 2.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.